call out our health systems to achieve greater heights in their patient care. It's really difficult for our provider community to keep up with the scientific advances, but we try in the RightCare initiative to help all of you do that by bringing in wonderful intellectual food for you, everyone. And I just want to point out to you that our staff here from UC Berkeley, Brian Vong, please wave, Megan Olson, have done a bang-up job on these materials for you all, and they're really very substantive. So I want you to realize that in this packet, you see a list of our goals, which is to drive the metrics of 75% of diabetic patients at goal for hemoglobin A1C 8, which is a just a very simple baseline that along with LDL 100, and I know that that's an old metric, but it's an oldie but goodie that still works, and blood pressure 140/90. Those three metrics together is what we drove in our initial NIH-funded community, where we reduced heart attacks by 24% in 4 years by simply driving those three metrics and using data to do it. So on the second page, you see our RightCare triangle. That aqua triangle is the secret formula. It's simply a synthesis of what all the really high-performing systems are doing. So the San Diego public health folks said to the medical groups there early on, look at this RightCare triangle deeply, take it back to each of your organizations, and analyze whether you're doing all those things. Because if you do all those things, you will meet the metrics of at least 75% in good control for hemoglobin A1C, LDL, and blood pressure. And with that formula, 3,826 fewer heart attack hospitalizations, acute MIs occurred over a 6-year period, saving $86 million in that county, with an estimate by RAND that would have saved our state over 44,000 heart attacks and $935 million. Hi, Dr. Blackbot, welcome. So I just want to point out to you that our staff has put together a synthesis of gold bar chart information on how we're doing on some key metrics across the 4 counties where we are, where we have initiated university best practices. And with that, I'm going to say welcome to Jim Kirwan. Come on up. Jim Kirwan has recently moved from Silicon Valley to El Dorado Hills. He is the chairman of the Diabetes Association, and he is going to give us a little bit of patient perspective. Welcome, Jim.
Thank you. I met Hattie, my fiance and I were at Chef Chu's in Los Altos. I know you've been there before. Yeah. Famous old restaurant. And if you go there, bring your ticket stub to Crazy Rich Asians, because one of the boys of the Chu family there, the brother, the guy that runs it, produced that movie, and they'll give you a free cocktail. Anyway, so my fiance and I were there, and we were sitting having a bottle of Rombauer, and we met Hattie and her sister. And Hattie, I found out what she was doing. I was greatly interested, because as a type 2 diabetic, I was first diagnosed 30 years ago because my blood sugar was fasting was like 125, and the doctor said, "Oh, you have potential, high blood sugar problems. Watch what you eat." Well, I'm sure I changed my behavior. I didn't really, because I always watch what I eat. Put on the fork and eat it. Anyway, and so were that today, I would have been put right on therapy for the type 2 diabetes. Instead, it took years before I started taking different drugs. It's very easy to say and hard to do to say, go lose weight and go work out more. And we were just talking about changing behavior, and it's hard to do if you have behaviors from when you weren't diabetic. So I watch what I eat now very carefully, and all of the medical things that happen as we age. So now I'm on not only low carbohydrate diet, but I'm also on a low acid diet now for another thing that hit me in the last year that I'm just today able to really get out and come do this. I had some kidney stones for the first time in my life, and I want that to be my last time in my life. So I went through and I didn't eat too much of the leafy greens and so on. Okay, from a perspective of type 2 diabetic, I think first of all, one of the key words when you have type 2 diabetes, for me at least, is guilt. And that is, you feel guilty when you blow the diet. I also feel for type 1 diabetics because they, on any day, could die if they don't dose themselves properly. I never realized that until I got on the board of the American Diabetes Association and started to get to know the endocrinologists better and the type 1. So the executive director of our group, it's the Northern California Local Leadership Board, is a type 1. He's been a type 1. He's, say, 55, so I was diagnosed when he was 10 or 11. And he's still alive, and that's good. I went to an event back in New Orleans for the American Diabetes Association, and I met a lot of people there who were type 1s who were 75, 80, 90 years old, which was probably unheard of a generation ago. So you all are leading things in all your own ways that are going to make this a better thing for people, and it's already been happening. So the first thing is you always complain about what you eat. You feel if you go out and you have one cocktail too many and say, the heck with the shot. I shoot insulin at night and I take metformin. Or you have a cocktail before dinner, and then when the dessert comes, you go, it's the old, I don't give a damn, and you eat the dessert. And then you get home, and you feel guilty when you take your blood sugar before you go to bed and go, what a dummy. So someday I hope I live long enough to change properly for it. But the perspective is that we're always having to worry about what you eat. It's just a big pain. It's not life-threatening or anything, but that's the perspective I have. So that's what I'm here to talk about. And we have some questions from an old type 2 diabetic. Not that old, I'm only 75. Okay. Anything more you want me to say? I yield the floor.
We just want you to be part of our group now, Jim. We're so happy you moved into our region, and we can get the Diabetes Association more involved.
Yeah, by the way, that's my goal when I met Patty and found out what you were doing. Sorry, is that the days of not vetted here between charities are over, and the new president of the American Diabetes Association, very, very bright and results-oriented, focused woman, is that it's collaborating with people. And what bigger collaboration when we realize, and we're all realizing it now, type 2 diabetes and type 1 diabetes, cardiovascular disease, it's all one thing syndrome. So we shouldn't have endocrinologists here and cardiologists here. We should be interfacing a lot. Thank you. Thanks for your time.
Thank you very much. And welcome to our guilt club, because we're all guilty because we all feel that we could do a better job in reducing cardiovascular disease in diabetics and in non-diabetics as well. So we're all here commiserating, can we do a better job, and how do we do it? To get us off on the right track to do that, our next speaker is going to be a distinguished individual, Francine Kaufman, who is, and I'll mention, was the previous Chief Medical Officer for Medtronic. You would say, what does diabetes have to do with Medtronic? Diabetes actually involves devices and drugs, so it takes both aspects of that, and Medtronic certainly entered into the device aspect of monitoring diabetes to provide better care. And as our last speaker mentioned, you could die any day if you don't get it right, and the devices are a way to improve that we'll be discussing today. She is also the Distinguished Professor Emerita of Pediatrics and Communications at Keck School of Medicine. She has 260 peer-reviewed articles. We're not going to go over every one of those today, but just a handful of that. And impressive to me, has 3 decades of NIH funding. If you've ever applied to NIH and gone through the grant process and gotten a list of where you are on the list, 3 decades is impressive of funding through the NIH for that. She is also, on the side, the president of the American Diabetes Association in the past, so that's a significant area. And I will also mention that she's been recognized for banning sodas in the LA Unified School District. Now, I mentioned that because I said we're all part of the Guilt Club, and as I walked in here today, I noticed, and you may have, sodas on the right-hand side of the RightCare initiative as we came in. Now, they may be diet sodas.
They weren't supposed to be for us, so I actually asked them to remove them.
Okay. Well, I just wanted to get that off of my chest right away, that we didn't have that, because I spent a fair amount of time on the consortium to try to eliminate school kids' sodas, and I actually had to negotiate with our former governor, Schwarzenegger, on it and other things. And I thought, boy, isn't it funny how these things creep back in if you're not vigilant for that. So we want to certainly thank her for her efforts in those areas and remind you that you won't see sodas again at your next meeting for that. So with that, I'd like to introduce Francine and also mention that in addition to doing all the things I mentioned, she also takes time to run diabetes camps in Ecuador and Haiti for 30 years. So Francine, welcome to Sacramento.
I do like to always suggest, if you look at me, I'm not a person you could imagine at a camp. But I do want to say that diabetes camps, and they're throughout California, they're throughout the country, and actually in the world, have probably had a significant impact on educating and improving the care of children with diabetes. But I want to today talk about technology. I did just retire as a chief medical officer at Medtronic Diabetes, and I went there 10 years ago to bring forth what we were calling an artificial pancreas, so a sensor and a pump and a tremendous amount of mathematics in between, so that we could automate the delivery of insulin, mainly for type 1 diabetes. Now, talk a little bit about where that also fits in type 2. I don't know if I need to go over this. Obviously, the status of what we are able to achieve for people with type 2 diabetes is not, I think, where any of us would like to see it. And despite increasing numbers of pharmacotherapeutic agents, and many patients taking 2 or 3 or 4 of them at a time, we're still not able to get where we need to. And the question is, how much more could technology play in the type 2 space? We know that glucose monitoring has a role, particularly for those patients who take insulin, and that perhaps continuous glucose monitoring, and for some patients, the use of insulin pump therapy may also improve their outcomes. And I do want to remind everybody, and I know everybody here knows it, that it's not a level playing field, particularly across racial ethnic groups, and that our minority populations actually have even greater difficulty in reaching these kind of targets. So this is now focusing a little bit on type 1. That's the world I come from. I am a pediatric endocrinologist. And of course, there are more type 1s who are adults, but the bulk of the onset is still in our pediatric population. There's a peak around age 5, and then there's another peak around 12 and 13. And this has just recently been published. This is the outcome of what we call the Type 1 Diabetes Exchange. It is the brainchild of JDRF, the Juvenile Diabetes Research Foundation, and the Helmsley Trust. The Helmsley Trust has been put together from monies left over from Leona Helmsley. You remember first she left her fortune to her dog, and then the family got that money back into a charitable trust, and the bulk of it has gone to understand outcomes and to improve care for children with diabetes, actually globally. And so they have been able to get together, this is about 80 different sites across the US with 22,000 patients all using a common data sheet to look at what people are on, what's happening, what's the complication rate, and of course what are the A1C values. So unfortunately, we haven't been able to really improve them over time. So in the blue is the most recent data, and the orange was prior data. And as a pediatric endocrinologist, I don't feel very good about this kind of data, where the real problem is in teenagers and young adults. And that should help us focus on what we've been calling in pediatrics a failure of transitioning care out of the pediatric setting into the adult setting, where most of these children go from being seen every 3 months. There's usually a gap during that transition of not being seen in a 6-month time period. And of course, a lot of other priorities that these individuals have as far as going to college, finding a job, going on with adult life, and it certainly does interfere with diabetes outcome. And if you looked at this, one would suggest that adulthood actually begins at age 30. And for all you parents out there of teenagers, I'm sure I don't have to convince you of that either. And then on the other is by age and by racial ethnic group. And again, the peak of this young adult, adolescent doing worse. And in addition, our children with non-Caucasian background also having less optimal A1C and glucose control. And then if we take them and say, well, what can we glean from this huge data set? And you can look at the solid black, which is those who take injections. The horizontal stripes, those who use insulin pumps, so you can kind of compare those two, suggesting that in a large data set, non-randomized, this is obviously takes into account patient ability to get the devices and to use them and to want them, so there's a patient selection bias that may explain pretty much all of it, but that the A1C is lower for those who use technology. And then the white is those who use finger sticks, injections and a CGM, a continuous glucose monitor. And the other last column is those who use pumps and CGM. And now we can see the importance of actually knowing those glucose values. So what does a CGM offer, a continuous glucose monitor? It offers, rather than a few finger sticks a day, which must be done with somebody with type 1 diabetes, or they have no idea how to dose themselves for their insulin. But rather than a few, it gives you 288 values a day. It gives you the ability to upload and look at a continuous streaming of glucose data. And of course now it can also be paired with algorithms and drive the delivery of insulin through an insulin pump. And in addition to those kind of things, this cohort, this type 1 diabetes exchange, still has what we would all agree is an excess of severe hypoglycemia, which means somebody has lost consciousness or had a seizure and certainly needs somebody to rescue them. So 6% of this cohort in the prior 3 months self-report that they've had a severe hypoglycemic episode, a little bit less in those who, in the older age range, this is particularly, in the higher age range, this is a particularly important issue for those who've had diabetes for a very long duration. Less with insulin pumps, trending to be less with continuous glucose monitoring. And it doesn't actually really matter where your A1C is, you're at risk for severe hypoglycemia across the board. And then looking at diabetic ketoacidosis, which is a severe, life-threatening episode of high glucose and the development of acidemia in the blood. 3% in the prior 3 months had an episode of diabetic ketoacidosis that obligates an ER visit or a hospitalization. And you can see now the highest frequency is in those who are younger. A little bit of a mitigation for insulin pump and CGM, so technology does help. And then the higher the A1C, so the less well you're chronically managing this disease, the greater the risk for diabetic ketoacidosis. It still is the leading cause of morbidity and mortality in children with type 1 diabetes. And then in my own career lifetime, of course I've been doing this for 40 years, so it's a pretty long career. When it first began, we were watching a slight increase in type 1 diabetes in youth. And then somewhere in the midst of it all, we started to see this massive increase in those youth with type 2 diabetes, associated with early onset, often of obesity, associated with being in an intrauterine environment in which the mother had gestational diabetes or pre-existing diabetes, higher in ethnic racial minorities, and now in centers like mine at Children's Hospital Los Angeles, we still see about 20% of our new onset patients have type 2 diabetes. And then you kind of imagine if you get type 2 diabetes at age 12 or 14, and it really is very, very rare before the time of puberty. By the time these individuals are young adults and entering into jobs and into families of their own, they've already had a significant burden of often very poorly managed type 2 diabetes. So this is a complicated slide, but maybe the most important thing I want to convey to everybody is we have talked and talked and talked about the importance of A1C. Matter of fact, during my ADA presidency, which was in 2003, and I suggest I was the second woman to be national ADA president. There's only been 2 since me, so you gotta get out there. That we are talking about more now than A1C itself. Because you can have an A1C of 7, which is at target, and be quite flat. You can have an A1C of 7 with a lot of glycemic variability and a huge percentage of time spent in hypoglycemia. And then how can we change the dialogue? Because now with continuous glucose monitors, we have the ability to look at 288 values a day, rack and stack them and say how much are in the range we want patients to be in. How much is in the hypoglycemic range? How much is hyperglycemic? And then dangerously or severely out of these limits. So a number of consensus groups have met. ATTD is an international group on diabetes technology. ADA, JDRF, many groups have been involved. A group beyond A1C has formed with all these different academics, international leaders in the diabetes arena. We've kind of all agreed now that glucometrics are important, that it's not just, we can't just continue to talk about A1C because it doesn't mitigate necessarily hypoglycemia and it doesn't actually account for this wide glycemic variability that may be a very distinct risk factor for cardiovascular disease. So if you start to read particularly the type 1 literature, and in addition the type 2 literature, those individuals with type 2 diabetes taking intensive insulin therapy, which is about 20-25% of the population, that we're going to start talking about what's the time in range for glucose values between 70 and 180. What's the time above 250? What's the time below 54? And we'll we'll all have to adjust to 54 so that we can be concordant with our colleagues across the globe who use millimoles, and that translates to 3 millimoles. Will still be also very important to discuss the events of severe hypoglycemia and diabetic ketoacidosis, but now talking more and more about glucose. And talking more and more to the patient about where do your glucose values lie. And in fact, this is turning out to be maybe a bit of an easier educational tool to use with patients. You're driving down a freeway, we want you to be between this lane and that lane, you're over here, it's too much on one side, you're over here, it's too much on the other, and we want you to do what's necessary to get back into the right lane so that you are in good shape. And this isn't just a kind of numbers game. We now have pretty good evidence, which is accumulating almost every month when the journals come out, that this time in range actually associates with complications of diabetes itself. And we can do time in range with the old diabetes control and complication trial data, and we can do time in range with type 2 diabetes and CGM, and show that the greater the time in range, the lesser the risk for complications, particularly microcirculatory complications of diabetes. So this is my favorite slide because it's just a ridiculous slide, but I, in my career, feel like I, along with my colleagues, and particularly along with my patients, have been climbing a mountain of how we care, particularly for those who require intensive insulin therapy. So all the type 1s, as well as this subset of type 2 patients with diabetes. And what we've done is we have advanced technology. It's been exciting, but we've also added burden to the patient as a result. How is that burden added? Is technology advances require a significant amount of education. These technology advances require that the patient wears them or has them on their body, which some don't like at all, others don't seem to mind quite as much. And it requires that they understand this not only improvement in A1C, but looking at that time and range of those other glucometrics so that they can see the advances that these technologies have been able to do. So first, when I began my career, we gave people 1 shot a day of insulin and checked their urine glucose. It was easy. Clinic was really easy. We got 4 glucose measurements a year every time they came to clinic. And at a pediatric clinic like mine at Children's Hospital in Los Angeles, we had children with the complications of diabetes during childhood. We've converted that. We said, well, once we got finger sticks available in the early 80s, that 1 shot a day was not adequate enough, that people needed more shots a day, so we went from 1 to 2. And then, of course, we went from 2 to 3, and now we are however many shots it takes, what we call multiple daily injections. So every time you eat, you need to take insulin. Every time your glucose is out of that lane, on the high side, you need to take another shot of insulin to correct that. And then, of course, the only way you can know what to do is you can monitor with a finger stick, or better yet, you can use a continuous glucose monitor. And then we got to pump therapy. Well, why have to take out a syringe, and now, of course, it's in the pen form, and inject yourself so many times a day, when you could wear a device, an insulin pump, and program it to deliver that basal amount of insulin, and then reprogram it every time you go to eat and assess your glucose value. And of course, those are better matched when you use a pump along with a sensor. And then when I went over to Medtronic, it was my role to now advance how we could put those two together and actually automate insulin delivery. So we went first to, let's stop insulin if somebody has hypoglycemia. You can come to my clinic, you can ask a 7-year-old patient with type 1 diabetes, do you want to get insulin? Your blood sugar is 60, and they'll tell you, no, I don't want any insulin. So with the way we were delivering it, we were giving it even in the face of hypoglycemia. So with these pumps, we had the ability to shut off at a preset threshold. Most people chose the value of 65 milligrams per deciliter. If I get there, stop insulin, let me recover either by stopping insulin